CataractCoach.com, podcast episode number 41 with Dr. Kevin Miller. And our podcast is sponsored by Harrow Incorporated. Welcome back to our Cataract Coach podcast. And today we have one of my mentors from back when I was a resident. You'll find out the truth about when I was a resident. It is Kevin Miller, cataract and refractive specialist at UCLA at the Jules Stein Eye Institute. Kevin, welcome and thank you for doing this.
My pleasure. Thank you for inviting me. I'm looking forward to the conversation.
Well, one thing I loved working with you when I was a resident was you were involved in like cutting edge. Like in 1997, you were doing toric IOLs. Back then, there were silicon plate haptic lenses.
That's right. I remember going to a meeting at I think it was the Academy, could have been ASCRS, and I was getting excited because Star Surgical was going to launch the first toric IOL in the United States. And so I was, visibly, I was really kind of anxious to find out when is the FDA going to give approval. So I was over at the Star counter and chatting it up with the people there, and this woman from India came up, and we were in the middle of a conversation about the launch of the toric, and she goes, "What you got going on that's new?" I go, "Oh, we're anticipating the launch of this new toric IOL, first of its kind in the United States." And she goes, "Oh, we've been doing that for a couple of years in India. What else you got?" I felt about this big right about then. But yeah, we try to stay on top of what's going on,
Yeah, that's actually an important point, is that certain technologies that seem so common and routine around the world, like, for example, iris claw lenses for treatment of aphakia.
Right.
We just don't have.
No, and we probably never will, which is sad. We don't have options.
Yeah, we're limited there. And you also were involved very early on in the prosthetic iris development. That I thought was amazing.
Well, I've been involved in 3 different iris devices over my time here at UCLA. So like most of us, I saw patients coming in that had iris defects that were just too large to repair with sutures. And, back then you had patching, you had dark sunglasses, you had tinted contact lenses, and that was it. And then over in Europe, they had some of these iris devices that we did not have access to. So I didn't think most of the patients that came to me had already done the contact lens, tinted glasses, or eye patch thing, and they were looking for a surgical solution, and we didn't have one to offer. So I looked around, found Morture and Oftech had devices, and reached out initially to Morture, asked them if they were interested in doing a clinical trial in the United States, and they said, no, it's too expensive to bring things to market over there. And I said, then, well, would you mind if I ran my own sort of compassionate use clinical trial? And they said, go for it. So I did. And it took years to get through the FDA, the whole process. But I got my own investigational device exemption to implant their devices, and altogether implanted 64 of them of different varieties.
Wow.
And then I got involved in Oftech with their 311 product. And then more recently, got involved with a human optics device.
Right, that one looks particularly amazing. I've seen a lot of your videos there. I like some of your pros. We featured here on Cataract Coach. I'll put a link below of a video of you doing the prosthetic iris, where I loved one technique, which was after you have it in place, use the vitrector to clean up any ratty original iris.
Yeah, so you get into the nuances and the cosmesis of this after you've done a whole bunch of these things. And one of the things you notice as you critique your own photos and videos is that the pupillary margin that's left in the eye tends to be darker than the rest of the iris tissue, and so it really stands out as like a line over the artificial iris. So over the last 4 years or so, I've been taking a vitrector and just chewing up that darker pupillary margin iris tissue, and it just cosmetically looks a whole lot better. I don't think functionally it matters, that pupil sphincter is not doing anything in the eye once you have an artificial iris. And so why not make it pretty? So that's what we do nowadays. We make it pretty.
Yeah, and the results just are amazing. I've seen a lot of the videos that you posted there. And, the stories, too, are so dramatic for these patients, because it's really like it fixes them, not just in their eye, but it fixes like their soul. These patients are so appreciative.
It's one thing you do not appreciate as an ophthalmologist until you've done a couple of these. So these patients come in and they complain about their vision problems, right? Their eyes sensitive to light. They have all kinds of glare. They can't drive at night. Quality of vision's bad. And you hear all about that. You do not hear them say they're embarrassed with the way their eye looks, or they have esteem problems or emotional problems. They don't tell you that because It would be embarrassing. They're ashamed, and so
Mm,
they don't put their shame out there. They put their, the things that they're acceptable, the vision complaints. When you talk to these people after the surgery, they don't talk to you about how much their glare has gone down, even though it has, how much their vision has improved, even though it has, or how much less sensitive to light they are. They tell you, oh my gosh, I look normal now. My friends, they can't tell that I have an artificial iris.
yeah.
I look normal. That's what's really bugging them. I mean, yes, they want to see better, but the emotional impact of having an iris defect, you cannot even begin to estimate it when you see these people as an ophthalmologist. You only find out about it afterwards when they then tell you how they feel emotionally.
I mean, that makes a lot of sense because in a conversation with the person, if they have a very damaged iris, you just tend to stare at that one thing and they feel self-conscious. I get it.
Mhm. Mhm. Yeah, nobody wants to sort of feel like most of us will sort of feel less of ourselves if we show emotional distress over some physical impairment. Like it's like we have to suppress that. We're not allowed to talk about those things, right? Even though it's down in there. And
Yeah.
so I've heard these stories so many times now. I know it's down in there. And so then I obsess about the cosmetics. And one of the things you have to do when you talk to these patients, can't oversell. I tell them all the color won't be a perfect match. The pupil may not be perfectly centered. The pupil is not going to be the same size as in your other eye.
Right.
And also go, yeah, it'll be so much better than I have it right now that none of these things will bother me afterwards. Oh, yes, they will. They will bother you because you're going to have a frame reset.
Right.
The little things now are going to become the big things later on. And the big things, you'll just completely eliminate them from your conscious because they're gone now. But the little things are going to bother you.
So
You
maybe
say they won't. You say they won't, but they will.
so you have a rule that after surgery, they're not allowed to look into a magnified mirror, right?
Yeah, no complaining. You sign this piece of paper. I told you.
So how many of these have you done now? These more modern designs? You did a lot, 60 something of the mortar ones. How about the more modern?
Yeah, I don't actually. I should count. I don't even know how much I've ever been paid on one. I've never looked at my finances, so I'm pretty bad as a businessman. I'm going to guess I've done a couple hundred, but I
Wow,
don't even know.
that's an amazing experience. Yeah, I think in LA, you're certainly the person to send them to. And
There's Nicole Framp, who's also excellent.
well, no, she's fantastic as well. But I mean,
Yeah,
for me,
and
you're
before Nicole, it was Sam Maskett.
for sure.
So Sam and I were the two in LA doing it. Sam's, of course, no longer doing patient care, but Nicole's picking up the baton, and it's great having somebody else in LA that wants to do these things because they burn you out. I mean, these are hard cases.
So you tell the patient your surgery is going to take like a week off my life. I hope you can.
Yeah, and a lot of arterial wall thickness,
Damage to
will
your
be added.
yeah, no, it can be very stressful. Like one of the things I really loved learning from you when I was a resident, obviously the surgical techniques and this and that, but the way you talk to patients is probably more important. Give us some pearls about that because you were like the master of these patients.
This is so simple, actually. This is like, how would you want to be talked to as a patient? Then do it. Do the same thing that you would want done for you. It's that simple. When you're in the operating room, talk to the patient. Tell them what they don't want to hear the play-by-play. They don't want to hear you're cutting the eye now, be real still, or whatever it is you're doing. I'm doing the capsular excess, don't move. You're going to feel some cold eye drops. Here they come. I'm going to put this thing in your eye to hold your eyelids up, and you're going to feel it's okay to blink against it. I'm going to start taking out the cataract now. You're going to feel some cold fluid. You're going to hear the machine making some noises, ding, ding, ding. Just talk to them so that they know kind of what's coming up. You're going to feel a lot of pressure on you. I'd make it worse than it's actually going to be. You're going to feel a lot of pressure on your eye as this suction device sucks onto your eye for the femto part of the procedure. So make it worse than it's going to be. Tell them what they're going to feel. Don't tell them what you're doing. They don't care.
Right.
Tell them what they're going to feel, and so they can anticipate it. And then you can get through these cases with very little anxiolytic medication intravenously. Just topical talk. Is what we all been. We've all learned. Vocal, local. Just talk to them.
Right. I guess, and also important to under promise there and then over deliver.
Mm-hmm. And always tell them it's going to be a little bit worse than it actually is going to be.
And then they're pleasantly surprised.
Yeah, exactly.
Then they say, oh, it wasn't all that bad. Now, you mentioned femto. What role is femto in your practice now? Because we've had femto in the U.S. since, probably 2011, so a dozen years now.
Mm-hmm. In all the studies, all the financial studies have basically shown that it's certainly not cost effective, and it doesn't improve visual outcomes. But then neither does femto for LASIK flaps either. The data out there basically don't show that it's any better than a mechanical microkeratome. Now the studies were the way the studies were done at the time is that femto flaps and wavefront optimized, wavefront guided treatments came along at the same time, so they weren't parsed. But there's really no data that shows a femto flap is better than a mechanical microkeratome flap, although we all know that they are. But you can't find data to support that. Same with femto cataract. There's no data that shows an outcome is better. I don't think you get a better effective lens position out of femto. I think that the capsular axis size and location don't influence the lens position. I think that's done at the capsular equator with the haptics and the angulation of the haptics with the optic. But would anybody argue that a femto incision or a capsular axis is less precise with the femto? Of course not. It's way more precise. So we have precision without the next thing that makes that precision critical. For instance, in the early days of phaco, we did this 3 millimeter incision, 3.2 millimeter incision. We took out the cataract to a small incision, and then we got to open up the incision to 7 millimeters to put our PMMA lens in, right? Why would you do phaco? A lot of expense, additional expense, and for no benefit. Then we got foldable lenses. All of a sudden, boom, it made sense now. We haven't had that leapfrog event in femto yet. I think it's coming. It'll come probably with accommodating lenses. I know you're interested in that. If you have an accommodating lens, it has to be perfectly centered. It has to be maybe even hooked to the anterior capsule. It has to be a perfect size and perfectly centered anterior capsular axis. Then maybe we not have that leapfrog event that catapults femto, second laser assisted cataract surgery into you have to be able to do this. But right now, we do it because it's more precise and patients ask for it.
What about the incision? You mentioned incision. Even if I use a femto, in our center in Beverly Hills, we got 3 femtos. I got no shortage.
Right.
Even if I use a femto for, let's say, a capsulotomy or for nucleus division, I'll still use the diamond to make the phaco incision. I don't like the femto corneal phaco incisions.
Right. When you look at the Medicare guidelines and the ASCRS and AAO response, you find that there's only 3 ways that you can bill a femto procedure to a patient. So you can't charge a patient for laser-assisted cataract surgery, laser cataract surgery. That would be Medicare fraud or insurance fraud. So there's only 3 safe harbors. One is clear lens extraction, so everything's on the patient. The anesthesia charge, the hospital charge, the femto, the lens, everything's on the patient, and that's a clear lens extraction. The second is what I call astigmatism management, where you're using the femto laser to basically make corneal incisions that are non-covered services.
Arcuate incisions.
It could be a phaco incision on a steep axis. That's an arcuate. That's a relaxing incision. That's an arcuate incision. So 80% of my astigmatism management is actually phaco on steep axis. A lot of people are not comfortable with that. But then if you do a arcuate incision in addition to your phaco incision, then that counts. So that's the second safe harbor, astigmatism management using the laser. And the third safe harbor, it never made sense to me, and so we don't do it here at UCLA. But the third safe harbor is they allow you to charge for the imaging necessary. So that'll be the OCT, the imaging necessary to implant a premium lens. Now think about that. What about the imaging makes a premium lens, a toric or multifocal EDF, different from the imaging for any routine just monofocal lens? Zero.
Right.
So this makes zero sense. And so it surprises me that at this point they haven't pulled the rug on that one, because it could be pulled any day because it makes no sense. So we do everything through the astigmatism management approach. So doing that, then you have to say to yourself, well, then I have to be making incisions with the laser if I'm doing the capsular axis fragmentation, and then knifing it in with a metal blade or a diamond blade for the incisional part. Then I can't charge the patient for that femto procedure because I have to be using the femto laser to do those incisions. So we we get results, yes. Usually when you can't open up an incision, usually just the paracentesis, so fine, you can just, open that up. But the main incision, you don't even have, it can be sticky, you have to just make the incision with the laser. If it's sticky and doesn't want it open, you can still open it up with the blade if you need to, but at least you've made the incision with the femto laser. And they're starting to audit on this now. They've already come to UCLA asking for records, justification for using the laser. So this will be going around. And so I think it's really important for those of us that do femtosecond laser assisted cataract surgery to make sure that we're doing it all above board. You don't want to go to jail over this.
So you could also just use it for an arcuate incision, let's say opposite your main phaco incision, which you can still make with a diamond.
That's
One
correct.
technique I liked from you, I learned this from you, was using a very skinny diamond and making the incision, and then you can enlarge it to whatever size you want. Two,
still do that. Mastel PhD diamond on a, it's a Tryman diamond on a nice, like Mastel foot-plated, single foot-plate blade. Beautiful.
How wide is it?
At the tip, it's 0.7 millimeters. Up the shaft, it's like 1.1 millimeters.
Yeah.
So Howard Fine is the one that came up with that configuration. It's beautiful. You can use it for everything. I use it for my arcuate incision. I use my paracentesis. I freehand a phaco incision when I'm not using a femto laser with it. So one blade for everything. It's so skinny that when you retract it, it goes way into the shaft. Nothing can get in there to ding the blade, which is a problem with the bigger diamond keratomes. They roll around, things get in there and ding the keratome.
Yeah, no, it's a neat technique. I've been doing that as well. So I use a small, I think it's 1.5 millimeter wide. And then I'm using the Storz blade, but then doing the same thing. And then I can enlarge it. Okay, I want 2.2, or this patient's going to get a little larger cartridge, like a 28 diopter lens. So maybe I'll enlarge 2.4.
Yeah. And after a while, you get pretty good at seeing what 2.6 or 2.2 or 2.4 looks like, and you just freehand it.
Yeah, surprisingly, you learn. Yeah, you get that the mental calipers developed.
Yeah. Kind of like my, my clock hour nomogram for doing astigmatism. So I can picture clock hours better than I can picture 47 degrees. But I can picture 1.4 clock hours, so I can just freehand those clock hours.
Right. No, exactly. I think we can link that too. I actually have a video of that about Miller's nomogram for astigmatism for LRIs, and it's basically like you said. It's I like the simplicity because obviously we can all think in clock hours very easily. And then I like that it's about a diopter, paired incisions, 1 clock hour per diopter. If they're all a little bit less, if they're young, a little bit more. I mean, it's just such an easy nomogram.
And you can use it for regular bow tie astigmatism. You can use it for asymmetric astigmatism. There's I have the general relativity and the special relativity. So special relativity is like, it's perfectly symmetrical, right? And you do your relaxing incisions, you do the phaco to one of them. Then you got the general relativity situations where, say, it's not a symmetric bow tie, it's steeper on one side than the other. So you can make a longer incision on one side, shorter incision on the other side. But the general situation is you add up the lengths of the incisions in clock hour, divide by 2, and that'll be your correction in the SIM-K astigmatism. So say you have a 0.5 clock hour incision on one side, 1.5 on the other side, add those together, right? That's 2, divide by 2, you get 1 clock hour. And then if you have the floppy bow tie, you just take the same nomogram, you just move the incisions onto where the flop is. So it works for all kinds of situations, both regular and irregular. Unlike a toric lens. The toric lens is only going to correct regular bow tie, symmetric bow tie.
Correct.
Because you can correct asymmetric bow ties with relaxing incisions, like beautiful. I can show you before and after. It's like, wow.
Yeah. What's your upper limit for corneal treatment of astigmatism with relaxing incisions? 2 diopters?
It was 3 before we had toric lenses. I could correct 3 diopters, but you have to be super aggressive. You're making 3 clock hour incisions. You're basically cutting half the cornea at that point. So incision scape, you end up usually putting a suture in through the phaco incision. And you're denervating the cornea. Some of that grows back, but some of it doesn't. So nowadays, I have a stepladder approach to astigmatism management at the time of cataract surgery. So
tell us about that.
Yeah, from a diopter under, I'm pretty much phaco on steep axis, unless it's in the horizontal realm, in which case I will do a relaxing incision on the other side. Okay. So from 0 to 1 diopter, generally I do phaco on steep axis. Again, horizontal, I will add a relaxing incision. From 1 to 1.5, I do paired incisions, and then from 1.5 to 4, I do toric lens, and then from 4 up, I do toric plus relaxing incisions.
Well,
So I can get 6 diopters. You know, I don't. So to answer your first question, I don't really go above 2 diopters now, and I only do 2 diopters if it's on top of 4 diopters of correction with the IOL.
yeah, I mean, I'm with you. For most cases, when you have such regular and symmetric corneal astigmatism, I'd rather do a toric lens. I think to me it's much more accurate.
Yeah, of course. Yeah, but sometimes you don't have access unless you want to go through the horrific appeals process of getting a lens in from Europe, you know, going through the compassionate use pathway. That's a lot of work.
For sure. Now, you got into refractive cataract surgery before it was even called refractive cataract surgery. Like I said, when I was a resident in 1997, maybe I'm dating myself or dating you, you had where at that time, most people just didn't really look even twice at the refractive outcome. You were sitting there again with the toric lenses and LRIs and really sweating the details to get a refractive outcome.
Yeah, ever since I can remember, I was doing refractive cataract surgery. Back when I was a resident, actually, in the late '80s, early '90s, I was kind of thinking refractively. Most people were at the time, you know, Spencer Thornton and Johnny Gayton, blanking out some of the names. They were all talking refractive, but it tended to be kind of isolated. Jim Gills was talking refractive back then, but it tended to be like certain cases they would focus on, the others would just get regular cataract surgery. Like that, why not take every patient and approach them as a refractive patient? And the easiest refractive surgery to do is just move your chair around so you're operating on steep axis. I mean, that's simple, but it covers 80% of my refractive surgery today.
Right. Or even if
a
it's
lot of people, they get trained on like operating in one spot. They never want to move from that spot. And there's a cost to be paid for constantly moving your chair around because it just slows you down. But, you know, for me, it's worth it. You know, I would rather do 1/3 the number of cases, make the same amount of money, have less stress in my life, and get a better result.
Right.
I think you would probably prefer that also.
I like the path of happiness and the path of least grief. Absolutely.
Yeah. Happy patient, happy doctor, you know?
Right. But even as I remember when I was a resident as well, doing paired full thickness phaco incisions on the steep axis, because we're at the county hospital or the VA, and at the time, there were no toric lenses available. None of it. And so if you want to treat it, and then we didn't have LRI blades. The county hospital is not going to buy that diamond LRI blade.
Yeah, you were inside the eye or not. Turns out now, as you know, most of the strength of the cornea is in the anterior fiber. So if you just cut halfway through in an old person's eye, like, 60 and above, you're going to get a nice effect. You don't have to go to, 100% or 90% of depth. You just got to get to the first half. So most of the nomograms, like the one that I use on the femto laser, it sets the depth to 80%, but you get the same effect at 70% and 60%. When you get a young person, then you do have to go deeper.
Yeah, that's an important point. And that is, a lot of times the nomograms that were traditionally done were at this, like you said, 90+% depth.
Yeah.
And boy,
I did RK back in the good old days. In RK, you would find this thinnest part of the cornea, usually, central or paracentral. You would set your diamond blade to 100% of the thinnest part of the cornea. Because, as you put that blade, you plunge that blade into the cornea, you're going to get compression at the leading edge. You're not going to get to that depth. You're going to get to something like maybe 80% of that depth. But you had to get super deep to get an effect in RK, because those young corneas, don't bend as much. But in older eyes, especially with arcuate incisions, you don't have to go that deep.
Interesting. Yeah, that's an important point, because when learning LRI, the last thing you want to do when you're learning to do an LRI is have a perforation on the table.
Yeah. Well, you will, So the thing is with the perforations, they're going to occur inferiorly and they're going to occur temporally. Those are your thinnest spots in the peripheral cornea, inferior and temporal. So you don't need to go super deep. You don't need to measure the corneal thickness and get get a micrometer diamond knife. You can just do a fixed blade depth, 450 to 550, somewhere in there, 500. You're not going to perf most of the time. And if you perf, don't jam the knife in and just do a quick cut. Pop it in and just kind of slowly go across. Have a dry field. And if you get a leak, just lift up a little bit and continue. I've never had a perf lead to any problems ever, and I've perfed 10 times.
Sure. So would you put a suture in on those and put a band?
I just hydrate them usually.
Just hydrate because it's a micro perf thing, because you see
it's usually micro. You go slowly. You don't go fast.
That's probably a key point. If you go fast, you'll get the huge perf.
Right. and you have
now
iris.
you put sutures in.
That's right. So you don't do that.
Very interesting here. What are your favorite lenses these days? What's like your fastball? What do you like doing? You don't have to mention any names, but just kind of class of lenses.
So I like, on the monofocal side, I like lenses that have a hard surface,
Okay.
that don't have glistenings, that don't scratch so easily when you're manipulating them inside the eye with instruments, that also don't pit so much when you're doing a YAG capsulotomy. So a good hard surface acrylic lens, single piece acrylic lens, that would be my go-to monofocal. My go-to multifocal nowadays is a trifocal multifocal. And there's only two on the American market. You can probably guess which one's the more popular. So I used the more popular one. It's a bit of a soft surface.
So yeah, Panoptic, so it's the one I'm using as well.
Okay, sure. It's a Panoptic lens. I like that one. I actually have no experience with a synergy lens, but I've learned from my colleagues internationally and nationally that who do have experience with both synergy and Panoptics. They all seem to like Panoptics better. And I think there's optical bench data to bear out why. And of course, J&J is very aware of this, and they will have another lens shortly to help address some of the issues with the synergy. I'm sorry, with the synergy lens. So I like the Panoptics. It's my go-to multifocal. And then in terms of toric, it used to be Alcon's toric. I participated actually in the original Alcon toric clinical trial. I also participated in a 6 to 9 T6 to T9 trial. So I really like that lens. It's rotationally very stable. Of course, I have experience, as we talked earlier, with the Star toric lens. Talk about a lens of helicopters. Oh my gosh! But that's not an issue anymore because we don't. That's right. Off the market. Been off the market for years. I used to when the J&J lens. I think it was AMO when it first launched. When the ZCT lens came out. Yeah. I put a bunch of them in, and I quickly noticed. I just noticed in the capsule bag it would spin pretty easily. And I thought this is going to be a problem clinically. And I even alerted the J&J people in the first week. I think you're going to have complaints about lens rotations. They would quote the study saying, no, it's fine. It just stays where you put it. And then, of course, very quickly, you talked to John Burdell and Dave Harton. Sure, they were getting all kinds of hits on Astigmatism.com. That lens is CCT lens. So they did some modifications to the lens to make the distal haptic a little bit tackier. Sure. I mean, essentially, what they take the same lens, and rather than tumble polish the whole lens, they would like silly putty the distal haptics, and then tumble polish it, and then dissolve the silly putty. And just by leaving the distal haptic sharp edged, it just grabs the capsule better. Nice. And now that lens is super stable. We participated in the rotational stability trial of it's a ZCU lens now, and it was very stable. So that has become my new preferred toric lens.
Then your
because it's got all the things I mentioned. It's a hard surface lens. It doesn't pit. It doesn't scratch. It goes to it's got a nice injector. It goes to an injector without scratching, and it doesn't rotate. So it's a great lens.
And so your favorite monofocal lens is the Technis monofocal DC Boo?
DC Boo or DI Boo. Those are equivalents to me now.
Do you notice the near benefit from iHands compared to the DI? No, I don't either.
I don't. I think maybe if the patient dilates at night, maybe they get some benefit, but you're not going to be reading in the dark. So, right. and you wouldn't read with this lens anyways. I don't, maybe you see the dashboard better in the dark. I don't know. So I personally don't see any benefit. But we're playing with spherical aberration to gain depth of focus. Seems like we've been here before, right?
That's been many topics. Are you doing any EDOF lenses, extended depth of focus?
Not much, because I think the quality of reading vision is just not there, and patients are paying a lot of money. And that my experience is they've been a little bit disappointed with the reading vision on these lenses. Yeah. So I have 3 places where I use EDOFs. So the first is the patient who's a prior refractive surgery patient. They've had I don't do post-RK period. I don't do those at all. But if they've had LASIK or PRK, hyperopic or myopic, I will offer them an EDOF if they really want a premium lens. And it gives me like a 1 diopter landing strip. So if I don't hit emmetropia perfectly, I can, I've got about a diopter slop in which to kind of hopefully get emmetropia. So that's one use. The second use is for people who have been in monovision their entire lives and they're in love with monovision. They want to keep monovision. but they loved monovision more when they were 55 and then they got out of their contact lenses when they're 60s because their eyes got too dry or whatever.
Right.
Now they want to go back to monovision, think it's going to be the same, right? It's not going to be the same because they lost that residual accommodative amplitude. So, and I don't want to leave them 2.5 diopters anisotropic so they can read like they could read in monovision when they're 55. So this is a good place for an EDOF lens. You get one eye targeted for distance. It gets the dashboard on the car. You target the other one for the computer, so about a 1.25 diopter aniso, and then they can read with that eye. So it's great for the monovision person who wants to stay in monovision. I try to talk most of them out of monovision into multifocus, but when I lose that battle, then I do this. I do an EDOF with monovision. And then my third use for EDOFs is the patient who's got a little bit of macular pathology, maybe a subtle epiretinal membrane, some drusen, a little bit of stuff that's not ideal for like a full-on, like trifocal, multifocal, but they want a premium lens, and I think I can get away with giving them something. I'll do an EDOF.
Oh, fantastic!
That probably accounts for like less than 5%. It does account for less than 5% of my practice. I'm usually full-on multifocal. If you're going to do trifocal or old style bifocal multifocals, you got to nail the refraction. You got to have as close to a 0 diopter postoperative refractive result as possible. And people that do a lot of EDOS, I think they just are not confident in their biometry and their target refractions. And so, you can lower the expectations of the patient by telling them you're going to have to wear reading glasses, you might need some driving glasses, and put an EDOF lens in. And if they have low expectations, you'll hit that. You'll make them happy. The patients inherently that are getting a trifocal, multifocal, they're expecting spectacle independence, whether they say that to you or not. So you got to hit that, or if you don't hit it, you got to have a way of getting them there with touch-up procedures.
So you said if a patient comes to you with a history of monovision, with contacts, maybe even with a mild degree of LASIK, you still switch them over to a trifocal?
Yes.
That's interesting. I don't know. It seems kind of counterintuitive. I'm almost afraid to do that.
Well, because most of these patients did the monovision thing when they were in their 40s and 50s, right?
And then they're back
and they got out of it for a variety of their eyes are too dry or whatever. It just didn't work, but they want to go back. And you tell them, I can't take you back to being 55 where you have a diopter and a half of accommodative amplitude that you can still use.
Right.
So they don't, so I can leave you, back then we could leave you a diopter and a half, aniso, and you could still tolerate that. I have to leave you 2.5 aniso now if you want to read. They don't get that.
Yeah.
You won't be able to wear glasses to drive. They don't get that. I can always wear glasses to drive. Not after I really screw you up and make you really aniso. So I really try to get those people into multifocals because you don't have to worry about all those issues. They go away.
And then for the EDOF ones and the post-refractive patient, where are you going to aim then? So let's say it's a myopic patient. Let's say they had myopic LASIK done. And are you going to aim then for just ametropia still and just use that wide landing spot? Or would you shift that a little bit one way or the other?
I have been, Steve Schallhorn had a study out looking at refractive outcomes in all patients, not just refractive patients. And I learned something from Steve that I've applied across the board, whether it's refractive or not. I used to target ametropia, or if there was a choice between if the choices of the lens calculations were plus, say, 0.11 versus minus 0.18, I would, like in a heartbeat, pick minus 0.18. But he showed convincingly in like a lot of patients that you want to choose the slightly hyperopic target, unless it's way hyperopic. And the reason is it's genius. I don't think he even said this in the paper, but it's intuitively genius. When a patient's a little out of focus, right?
Okay.
If the natural tendency when you're a little out of focus is you try to get focus. If you are a little hyperopic, right? So you're plus 0.15, and you try to get in focus. What do? You try to accommodate. That doesn't work. But what happens in the process?
You get meiosis.
You get meiosis, and you get better vision just by trying to accommodate. What if you're minus 0.15 and you try to get better focus? What happens? You relax your accommodation. Your pupil gets bigger. It worsens your visual acuity.
I get it. I got
Yeah,
you.
it's like a no-brainer. So you would much rather be plus 0.15 than be minus 0.15, especially if you have a multifocal on your eye. So So now I target up to plus 0.15, or then I go to the first negative number after that. And I do that whether it's a regular eye or a post-refractive eye. So that gives me plus 0.15 on the hyperopic side, and then the EDOF, the EDOF 1 diopter, 1.5, 1.25 will give me that landing zone. And then it becomes better. Which formula do you use? I have my own formula, so I use my own formula. But there's a bunch of good formulas out there.
Yeah, that makes a lot of sense. Although, as someone who's a -2 myope, you can't convince me to have any type of hyperopia. On the court, I don't want it. I'm the worst patient.
Yeah,
I love being -2 OU spherical. It's like a blessing.
Well, you're going to get -2 lenses.
Honestly, I think that's probably what I end up choosing. I don't think I'd want to change it much. I don't want to be lower myopia, because then if I'm pseudophakic, it'll be too far out. I mean, I like the -2 range. 50 centimeters is like perfect. So
yeah, it's hard to please mild myopes. It really is.
Yeah, that's a good point. When I used to teach UCLA residents, which obviously I'm retired from now, but I'd always say when the lens calcs come up and it's like, oh, what's the IOL power? 17 or 18? Are you sure it's what the patient wants? That's a low myop.
Yeah.
Are you sure?
Low hyperopes, everything makes them happy. High hyperopes, you can't go wrong. Low myopes, high myopes, they're also easy. It's the low myopes. You have to spend a lot of time talking to them. It's just like the patients who are 45 and they want LASIK.
Right.
And they go, what's the problem? I can read just fine. I just want to improve my distance vision. No. No.
Really well for that. My near vision is great. Just fix my distance vision. Right, for that. Although, you know what, for the hyperopic patients, I had a patient recently who was very hyperopic. +8 was the pre-op refraction. And did cataract surgery. Patient ended up beautiful result. +0.5 OU, +0.25, +0.5 OU. And what the patient says, but I miss the magnification I used to get with my big chunky glasses. Right, because all the images are bigger.
Yeah.
Everything looks
and where these wrinkles come from, by the way.
Right, but she said, "Oh, now everything looks so small." I said, "Well, that actually is the normal size." So now I've taken in the account. Now, any patient who's a high hyperope, I say, the image size is going to change. It's going to be back to normal, not the magnified version. And I'm like, "Oh."
Yeah.
So.
Well, it's like their color vision. Eventually, they get used to the blue of everything, and they'll eventually get used to things being minified. But yeah, initially they everything's small now.
That's another great question. Where do you stand on the blue blocking versus no tint lenses?
I flip-flopped. I jumped on the bandwagon early on thinking, I should be doing what's best for my patients and giving them that, extra, retinal protection. But I made the mistake a few times in my practice, and I saw this happen a lot in clinical practice outside, patients coming to see me, where they got a yellow lens in one eye and a clear lens in the other eye. So I asked the obvious question, which eye do you prefer? Guess what the answer was every single time?
The clear one.
The clear lens. They all preferred the clear lens. And I made the mistake 4 times in my practice. I just apologize. I don't know why, but I ended up putting a different lens in. And they go, oh, okay, so that explains it.
No.
So when you hear this, this doesn't happen anymore. But when these natural lenses, yellow lenses, first came out, all you heard about was there's no problem with color discrimination. They did the Farnsworth 1 cell 100 hue test, no problem. So they don't perceive any difference in color. That's completely wrong. You hold this lens up, hold the clear one and the yellow one up against a white piece of paper. It's obvious. One's yellow and one's clear, and the patients can perceive it's obvious. So they prefer the clear one. So then what's the data to support? We have Petri dish data where you culture some, RPE cells and you blast the hell out of them with the ultraviolet light, and you put a yellow lens in front of one set of cells and a clear lens in front of the other. Okay. That's like, there's a talk that goes to the same effect with simulating the effect of like 1,000 warm showers over your lifetime versus one scalding hot shower. It's not the same. So is there any data that we can say this proves that ultraviolet filters are helpful for the human eye? No. There never will be.
But all the lenses have UV filters, right?
Every single one of them, but without any data. All data is circumstantial.
Right.
So if we don't have it for something even more egregious than high energy visible blue, which would be ultraviolet light, if we don't have data for that, how are we ever going to get data for high energy visible blue light?
Right.
So I don't, and to do that study, quite honestly, you'd have to take people when they're time for cataract surgery, you'd have to randomize them to a UV blocking lens in one eye, non-UV, or yellow in one eye, clear in the other eye. You have to follow them for the rest of their life and do serial photographs or some assessment of macular function.
Right.
Who's going to sign up for that study? Who's going to fund that study?
Right.
And the investigator is going to be dead long before the results are available. So guess what? That study will never be done.
But what about you look at light transmittance through a 25-year-old human crystalline lens, and that's not letting in all the blues. There's a little bit of a tint to it. You can look at a 30-year-old slit lamp, and you can see their human crystalline lens is not perfectly clear. It has a slight tint.
Yeah, so that's the teleologic argument. The lens becomes yellow because it knows that the retina needs protection, so it becomes yellow. Therefore, may be true, may not be true. But all I can say is I've asked a whole bunch of patients, which eye do you prefer? They prefer the clear lens eye. So now I've switched gears. I do not put yellow in unless they have a yellow in the other eye. And that's sometimes if you don't have the information, you really have to be a sleuth and try to figure it out. Most of the time I can tell if the lens is yellow.
Yeah,
sometimes it's hard.
Yeah, sometimes it can be tough at the slit lamp to even tell.
Right.
Which begs the question, if you look at their eye with a slit lamp at 16x mag and you can't tell that the lens has a tint, is it really all that significant? I don't know.
Yeah, I don't like to mix tints. I don't like to mix materials. You don't want it because patients are always going to have a slight difference in their vision outcomes, right? And they're going to look for any reason to explain the difference or to blame something on for the difference. And you don't want to give them something really obvious, like they have completely different lens implants.
Right.
Right. Different materials. They have a twinkle in one eye and they don't have a twinkle in the other eye. And like, how come you put these two different lenses in? How come I didn't get the good lens in both eyes? Right?
Yeah.
So anything you can do to eliminate that, you should. So yellow versus clear is a clear, easy one to avoid.
For sure. I also tell patients, remember, your eyes are sisters, not identical twins.
There you go.
And then when they come in covering one eye, covering the other eye, flipping back and forth with their hand, I say, stop.
Yeah.
That's bad for your brain. It prevents the eyes from syncing together. Don't do that ever. Just some fun little pros there. One other thing I enjoyed about you, which I learned from you as well, is that you travel a ton. You are international. Like I was recently last month in India giving lectures, and they said, "Oh, you were at UCLA before." I was like, "Yeah, kind of loosely affiliated." He says, "Do you know Kevin Miller?" Like, wait a minute. So, and then the month before that, I was in Chile, and you are like a celebrity in the Chile ophthalmology world.
Yeah, I go there every other year. I'm already planning my next meeting. Actually, it'll be in July of 2025.
Oh, nice. So tell me about that. So you certainly travel the world lecturing and teaching.
I like to do it. Early on in my career, I was fortunate to be involved in the early days of phaco and phaco training, and I still am. The courses I do. And I got invited because I was one of the few people that kind of understood the technology. I really understood the technology, I think, more than most people did. And so because of that, and people found out I understood the technology, I got invited. And so I would just to go someplace new. I would just say yes to almost any invitation that came along. And so I've been to most of Asia, been to most of South America doing teaching tours. And I love it. It takes there's a price to be paid, which is time away from the office means I've got an office overhead that I have to feed no matter whether I'm there or not. So it hurts the bottom line, but if money were everything, I wouldn't be doing an academic job.
Well, I thought it'd be easier in academia being able to get away to travel and all that.
That's the myth. No, it's not. It's maybe harder because I have unlike somebody in private practice who just basically has to pay the office overhead. I have teaching responsibilities that are uncompensated. I'm expected to do research, which largely, a lot of it's not compensated. I'm kind of expected to do things at the professional society level, being a reviewer for journals, being an editor for journals, and those are all, of course, non-compensated. So half my week is doing stuff that's non-compensated, but I have to pay my salary through seeing patients just like everybody else. So there's no, at least in my situation, I think this is true of many in academics, there's no salary support from the university. And I don't get a dime from the university. I don't get a dime from the state of California. I have to generate it. So time away means I have to stress more when I get back and, and make up for the time away.
Sure. But one thing I learned, though, after age 50, and since you taught me, if I'm after age 50, so are you, easily.
A little bit.
You know what? At this point, though, I just, I want to have the time to enjoy and travel and see the world and meet all these colleagues. And, I'll take home a smaller paycheck.
I wouldn't trade the travel for anything. I would not have gone to like 90% of the places I went to had it not been my job. Like
Right.
who goes to Myanmar for vacation? Like nobody. Or to Pakistan, nobody. Or to, I know I can just rattle off a whole bunch of countries, but I go because it's cool. I like to see the local culture. I like to taste the cuisine. I like to meet the people. And one thing I've found, despite politics, people are the same everywhere. They all want the same things. They want a decent life for themselves, for their kids. They want to have their kids, have their life be better than the life that they grew up with. And they all want good things. They all want to have a peaceful life. Doesn't matter if you're in China, into, whatever, Laos and Myanmar and South America, Europe, wherever. It's the same. Everybody wants the same thing.
For sure. No, I feel that too. People are fundamentally the same.
Yeah. So travel's great. Obviously we've done a lot of travel internationally. It's interesting to go to me and see who's going to pop up that Like for me, going on these meeting trips internationally is just going to see family now. Right. Every place I go, this is a group of maybe 50 to 100 of us that teach cataract at the international level, and it's the same 50 to 100 people at every meeting. Yeah, which is fun. I get to see my friends.
Yeah, that's the neat part. They're like I'll see friends. I was in Brazil earlier this year, and I hadn't seen Roberto Pineda from Harvard in a couple of years. Like, oh, there he is in Sao Paulo. How you doing?
Yeah. Well, I was just in Brazil for the Brazilian Society Cataract Refractive meeting. He was there for that.
Yep, for sure.
The last time we were there together, I said, hey, we were at a Peruvian meeting, and I said, hey, Roberto, I'm thinking of going to Machu Picchu. You want to go with me? Because I'm already going. You want to come with me? So we did.
Nice, that's fun. No, the friendships you make are very valuable. And you're right. Wherever you go across the planet, people essentially have the same values, same desires. People are fundamentally the same.
Mm-hmm. No, sadly, we have less as Americans to give or to contribute to the conversation when it comes to ophthalmic technology, because information travels really fast nowadays. And in many cases, the technology is actually further ahead in other countries because we have regulatory issues that slow down the deployment of things. I was in Egypt for several meetings in years past, and they were so far ahead of us and what they could do. I just felt small. Like I can't contribute to this conversation because we haven't started clinical trials in this yet, and you guys are already doing it like on a day-to-day basis. Right.
There's a lot of technology we don't have access to, but like you, I enjoy the international meetings to meet friends, of course, but also to learn.
Mm-hmm.
That's some amazing surgeries being done across the world.
Yeah, and getting into their operating rooms and kind of seeing how they do things, and occasionally being able to do some guest surgery it's fun.
Oh, that's right. You were at the Brazilian meeting too. You did a guest surgery for an artificial iris. I saw that. It was beautiful. That was fantastic. Do you think we need to have like a cataract refractive fellowship? I know you used to have a fellowship in years prior, but do you think that needs to come back? Can we make like refractive cataract surgery its own specialty, different than like cornea, which is not really what we're doing?
Yeah, I have lots of thoughts along this line. If you look at subspecialty ophthalmology, right? Every subspecialty has its group, right? So you have the American Glaucoma Society, and they have glaucoma fellowships. You have ASOPTERS has a plastics fellowship, APOS, and there's the Pediatric Ophthalmology Society, and so on. What's the largest subspecialty society in ophthalmology?
Probably ASCRS.
It's ASCRS. How many departments of ophthalmology have a division of cataract and refractive surgery in the United States?
Probably 0.
One.
Which one?
Ours.
Oh, like how dumb am I? I don't even know. How dumb am I?
You're talking to the chief of cataract and refractive surgery. Yeah, we're the only one to my knowledge. Most other places, cataract is part of general ophthalmology or comprehensive ophthalmology. Refractive is part of cornea. Those two things couldn't be further apart.
Right.
Just happens to be the cornea you're cutting on, but cornea and refractive surgery are just two completely different things. So, so in 2014, we, through my push, created a cataract and refractive surgery division to do at the educational level what every other subspecialty size has had going on in departments of ophthalmology for decades, right? Glaucoma fellowship, plastics fellowship, pediatric ophthalmology fellowship, retina fellowships, all represented by societies. But the biggest society is not represented in any department of ophthalmology, and by and large, except for miscellaneous fellowships, is not represented in any fellowship program. So one of my things I hope to accomplish in the next several years, I'm on the board of the AS here, so I'm in line to be president a few years from now. And one of the things I'd like to see accomplished is that we extend a greater awareness of the need for departments of ophthalmology to create cataract and refractive surgery subspecialty divisions, because it's a subspecialty in its own right, probably more sophisticated actually than many other subspecialties at this point, and then start rigorous training in that. Our residents all get to do LASIK and PRK before they leave, even if they're going into retina. They all get to use the femto laser to do cataract surgery, even if they're going into retina. And I think that's an important part of the basic resident training, and we should be training some specialty fellows in this. So currently, I participate in a fellowship that we've combined between the cornea division and the cataract refractive surgery division. So we share two fellows in amongst our fellowship. But I would like to see. So in the past, we've had cataract refractive fellows. I'd like to bring that back at some point.
Yeah, there's work also being done by RSA, Refractive Surgery Alliance, with Guy Kazarian. They have now fellowships that are actually refractive cataract surgery plus refractive surgery.
Yes,
they're private practice type fellowships, not really academic associated.
Well, that's right. So that's a private practice activity, which I admire. I think you don't want to carve the baby too small. So I think there's a initiative there to kind of make refractive surgery like its own little subspecialty area where like you can only do it if you're subspecialty trained in that. I think it's splitting it too many times. I think generally more training is better, but I think comprehensive training in cataract and refractive, which are natural cousins, that's the way it should go. Because increasingly, refractive surgery is going to become lens-based. You can't just be a cornea refractive surgeon.
Right. I think that arguably in the U.S., more refractive IOL surgery is done than refractive LASIK surgery or corneal surgery.
Oh wait, I mean, there's 3 million plus, or maybe 4 million by now, cataract operations. Each one of them could be called refractive.
Right. So,
and there are a lot of LASIK and PRK procedures, but not nearly as many as cataract. So I think that I think they're both important. We should be teaching lens-based and corneal-based refractive surgery together, not dicing it up.
No, for sure. They, like you said, they're cousins. They go hand in hand.
Right.
You got to cover the whole spectrum of refractive surgery, whether it's corneal refractive, phakic IOLs, cataract surgery. It's got whole thing has to be covered there.
Mm-hmm. And they're complementary. You do a multifocal IOL with some astigmatism management using a femto laser, and they come out with a little bit of mixed astigmatism. Okay, need to go to the cornea next. So I think, So I think we should be teaching to the standard that the patients expect, and also there's obviously you know this. There's economic benefit to doing that as well. Patients benefit from our knowledge and our ability to deliver, and there's from a Medicare insurance company perspective, there's a safe place to practice. Where you're doing some cash-based medicine. So why not?
For sure. No, I think you've got a good point there. It'll be nice when you have your own fellowship, get that going, and you got so much to offer. I mean, I learned so much from you as a resident, 20, 23, 25 years ago.
Gosh. Scary, huh?
It's wild even. But no, you obviously have a big passion for this. Where do you think we're headed now? Future of cataract surgery. What's coming in 5 years, 10 years? Where are we going with this? You've always had good insight here.
Well, I think the two holy grails are a combination. So will that actually pan out? We'll see.
Sure.
Everything looks good first year or two once it's in the eye, but then you have capsular fibrosis. So, we'll have to see. But I'm hoping something makes it out.
Sure.
That's better than the crystal lens, which is a joke. So we got to have something better than crystal lens. And I'm optimistic that actually will happen. So that's one holy grail. And the other is post-operative adjustability. And if you can marry those two things, have an accommodating lens that's post-operatively adjustable, and especially if it could be adjusted post-operatively over the life of the patient, and not like the LAL, where you got one adjustment and you lock it in, and then that's it. I like to see continuous adjustability over the life of the patient if that can be done.
Like
So
Randy was talking about refractive index shaping. He was on one of our podcasts, episode I think 13.
Yeah. So there's refractive index shaping in the cornea, what Scott McRae and his group have been working on for years. I think I don't think that's going to stick because you're working in tissue. And then of course there's been refractive index shaping in the lens itself, the Perfect Lens group in Irvine. Unfortunately, Joseph Billet just passed away. He was the principal biophysicist chemist that kind of developed that technology. I'm not sure where it's going to go with his passing, but that was to me the most promising technology.
Sure.
Where you can basically create a lens inside of a lens just by changing the hydrophilicity of the material. That's really cool. And if you can do that in a very thin sliver of the lens, and you can remember where that sliver was, and then make it, put other slivers in as you need to. That, I think something like that is going to be phenomenal. I think if you can get a lens implant that's adjustable, like any model, not like you have to put in the light adjustable lens specifically, but any model lens, and you can just adjust the power post-operatively.
In perpetuity,
that's like 10 times bigger than LASIK.
Yeah.
I mean, way bigger than LASIK.
Yeah,
so I think that's the future. I think accommodation and post-operative adjustability, those are the future. Imagine if you, with like the light adjustable, the Perfect Lens technology, you can put a multifocal pattern, you can put an EDUF pattern, you can put a toric pattern. You could do a wavefront pattern. Like, why not correct some of these high-order aberrations? They got a decentered LASIK ablation. Okay, we can fix that on the IOL. That would be pretty cool.
That'd be wild. Yeah, very neat. Yeah, neat things are certainly coming. I mean, like you, I'm thankful every day that I'm an ophthalmologist.
We're in the best profession ever, and we're in the best part of the best profession. You may go into glaucoma. Not if you're a glaucoma specialist, please, forgive me, but yeah, we're in the best part of the best profession.
No, for sure. The only sad part is that I'm solidly mid-career now. What happened? Where did the years go? So hopefully I got another 20 years of this in me. I think that'll make me happy, but we'll see. Well, Kevin, a pleasure talking to you. I really just can't thank you enough for being such a great mentor to me when I was a foolish resident in 1997 to 2000 there at UCLA at what I still call the Jules-Stein Eye Institute. Yes. Jules Beck and Jules-Stein. But no, you've been an inspiration to so many people, and obviously a great learning resource for us all. So thank you again, Kevin.
Well, thank you for inviting me to do this, and good luck with the podcast series. Looks like you got a lot of people lined up, and wish you the best.
All right, thanks, Kevin.
Bye-bye.
Thanks for enjoying that podcast with me. I trust you learned a lot and found it quite entertaining. And thank you to Harrow for sponsoring this podcast. Remember, we have a new podcast every single week. It's available anywhere you find podcasts on any service such as Apple, Amazon, Spotify, Google, and more. Of course, we've got it as a YouTube video. And of course, it's part of our CataractCoach.com library. I look forward to checking in with you next week.